I want to introduce Dr. Peter Libby, professor of cardiology at Harvard Medical School, Mallinckrodt professor of medicine. Like Tom Rando, Peter is a marathon runner, and he's actually a Californian originally, but he's been at Harvard for a long time. Peter has had a prolific career that has spanned laboratory research in vascular biology to leading major clinical trials. And I could not take all the time necessary to talk about all the prestigious awards that he's received. So we're honored to have Peter. He brings a wonderful message today and will be a great moderator. Thanks, Peter.
Great, thanks very much. It's wonderful to be here with my co-panelists, Pam Taub from UCSD, Abel, who's the François Labou professor at the University of Iowa, and Paez Zanad, who comes to us from Nancy, where he directs one of the INSERM units, and he is a prolific clinical trialist. And I have to correct the record, I do half marathons, not marathons, and they get slower every year. So if I could share my screen for a moment, I'd just like to set the scene with a couple of thoughts, just to get the conversation going. Let me say that this is a wonderful opportunity for us to exchange, and it's not going to be talking heads. I'm just going to try to fan the flames a little bit with a few thoughts for us to discuss. There's a lot of fatalism about the genome, that our history is written in the DNA that we inherit, and that there are what we in preventive cardiology have called the non-modifiable risk factors of obviously genetic background, but also sex and age. And I think we're here to challenge that idea and think about whether we can change some of these supposedly non-modifiable risk factors. We've just been hearing about changes in behavior, physical activity, exercise, etc. And this slide sort of synthesizes some thinking that me and my colleagues have been doing about this. We have axes here of time going from left to right. You can see my pointer here. Maybe I'll pick up the laser. It's easier to see. And here is the hand that we're dealt at conception. But an awful lot can happen during the years. We can have somatic mutations. We can have exposure to a lot of environmental risk factors. We can have epigenetic modulation of our DNA and our histones, which regulate gene expression. We have non-coding RNAs, which are a whole burgeoning field of their own, which can modify gene expression and are not necessarily regulated by the inherited genome. And with time, we get expression of these changes as diseases. Atherosclerosis, atherosclerotic events, and senescence. Senescence at an organismal level, senescence at a cellular level, and we've been hearing about some of that. So this is looking at aging and cardiovascular disease through my lens, that of inflammation. And this slide shows that inflammation is part of the process of atherosclerosis from its very inception, too often in youth, through to its thrombotic complications that preoccupy us in our clinical practice. And the question is, I'd like to have the panelists discuss this: could inflammation hold a key to modulating cardiovascular risk that we've attributed to the non-modifiable risk factors? Let me hearken to some of the data of my colleagues, the Mass General colleagues and collaborators. This is Amit Kara, who together with Sek Katharesan and Pradeep Natarajan have put forth generations of polygenic risk scores. So that's the information that we inherit. And to see whether if we take 4 of the behaviors that are in the list of things that we should strive to change in the American Heart Association if we can modify that genetic risk. And sure enough, in 3 different cohorts, A, B, and C, for every stratum of genetic risk, we can modify that by changing our behaviors. And I want to call attention to one other point here, which is quite important for us to discuss. And that is that if we look at a study which is 100% women, we start out with an absolute rate of 10-year coronary events that's less than half that in a mixed population, such as the atherosclerosis risk in communities, which is 45% male. But there's a problem, and that is that this protection against cardiovascular disease that women enjoy earlier in life, being the stronger sex, that it tends to diminish with age, so that by the time we reach the elderly old, and this is increasingly what we're looking at, as I'll show you in a moment, there's a catch-up of women with cardiovascular disease with their male counterparts to survive. So in 1960, this is how the distribution of men in green and women in orange by age looked. It was a pyramid. And if we project further, and this is US Census Bureau data, we see that there's going to be a predominance of women in the older strata of our population, and that many more are going to be surviving to old age. So this is the challenge that we face looking forward. How can we forestall the looming threat of an epidemic of cardiovascular disease, particularly in women? So we're here to talk about the things that can change the biology that drives the inflammatory process and thus cardiovascular disease, stress, sleep interruption, unhealthy diet, sedentary activity, and we're beginning to chip away at a molecular level, bit by bit, at these various factors. This has led to the concept of inflammaging. Now, right now, it's not terribly rigorous, and it's pretty soft, and anyone can draw a nice little chart like this invoking all kinds of transcription factors and mediators and an age axis and all of these different things. So our job, our challenge, is to lend rigor to this concept, figure out what fits and what doesn't fit, and most important, what we can do about it to forestall the age-related chronic diseases, which is now becoming a global epidemic because of our success in treating communicable diseases, at least until the last 9 months or so. And we have to open our aperture beyond the usual Framingham risk factors that we're all familiar with and know in large part what to do with, such as hypertension, hypercholesterolemia, and think about the other arsonists that set the artery aflame, including some of the non-traditional lipid risk factors, visceral or ectopic adipose tissue, which is associated with obesity and sedentary activity, the microbiome, which is a whole other story, and then the consequences of those somatic mutations, clonal hematopoiesis, which turns out to be a potent, independent, common, and age-related cardiovascular risk factor. So I think I'm going to stop there, having just tried to set the stage for this discussion, and I'd love to get some reaction from the panelists to some of these thoughts. Pam, you work in wellness and prevention. What's your take on what we can do to face the problems of the future?
Well, I think we're in a new era where we're really recognizing the synergy between lifestyle intervention and pharmacologic therapy. I think previously we've traditionally practiced either we use pharmacology, or there's some physicians that really do kind of lifestyle medicine, and now we're starting to merge the two. And I think this is where a lot of the basic science helps us in terms of lifestyle strategies. I think, as you pointed out in your slides, there's a lot of lifestyle strategies that modify the event rate. And so what we are challenged with now is figuring out how can we personalize these strategies for our patients. So for instance, one of the things that I do a lot of work on is fasting. And we've seen in our studies that when you take someone who has metabolic syndrome and you ask them to do a simple thing, which is just fast for 14 hours a day, that you reduce their lipids, you improve their blood pressure, they lose weight. And you combine this with certain evidence-based medications, whether it's a statin or icosapent ethyl or SGLT2, you have really incredible synergy between those two strategies. So what I would like to see is more of that integration between lifestyle and pharmacotherapy.
So how do your patients cotton to the fasting for 14 hours? What are your motivational tools to get them to stick with the program?
First of all, showing them the study, giving them kind of a synopsis of the research, because there's a lot of unsubstantiated lifestyle interventions that are not good for our patients with cardiovascular disease. The ketogenic diet is a great example of how this is not an appropriate diet for our patients. And so what you have to really do is you have to show them the evidence and say this is an evidence-based strategy based on a small study, of course, and then really telling them that this is a flexible strategy. So for instance, with fasting, you can modify your window. So for instance, a lot of patients will eat from 8 o'clock in the morning to 6 o'clock at night, and then they'll fast from 6 p.m. to 8 a.m. But what I tell them is if you have an event with your family or you have a late dinner, you can move that window around so it can adjust with your life and all of the activities that you have in your life. So it's really conveying that it's a very adjustable strategy, and also that they don't have to do it every day. Our studies show that if you do it 6 out of 7 days a week, that there's benefit. But what's nice about these lifestyle strategies is you can ease them into it. So you can say, well, right now you're eating all day and you're not eating, you're basically eating until you go to bed. Why don't you start by doing 12 hours? And then after a month, start increasing that fasting window. So it's something that they can kind of ease into, and it's not an all or none phenomenon.
Great. So Dale, you're the only non-cardiologist on the panel, and you have a chance with a minority view as a diabetologist, endocrinologist, and also as the chairman of internal medicine. You have to have a broader perspective than cardiologists who have a much narrower focus.
Yeah, well, Peter, so what I would say is that another aspect to your notion of kind of inflammaging is that there are changes in metabolic homeostasis that also occur with aging as well. And certainly from an endocrinology perspective, clearly as we age, we have dysmetabolism, we have insulin resistance, we have alteration in our glucose homeostasis. And I think that there is clear overlap between altered systemic metabolism and inflammation that develops certainly in adipose tissue, and I would imagine as well in blood vessels. And certainly epidemiologically, as you know, diabetes just amplifies the atherogenic state. It's like putting more gas on the fire. And so I think that as we think about lifestyle, etc., in aging, we really should also view it through the lens of kind of reversing many of the metabolic abnormalities that occur in the context of aging, that I think will then have many effects beyond just preventing diabetes, but also improving cardiovascular health.
So, Faiz, you have a foot on both continents, and it's amazing in France where every street corner has a beautiful boulangerie pâtisserie with all these incredible attractions. And you see the kids lining up after lycée to get their little chocolate croissant and things, yet they're all thin. So what's the secret? What's the French recipe for staying thin and avoiding some of the burdens of dysmetabolism? Oh, you're muted.
I was in mute. I'm pretty sure that you know better than me because you spent quite a bit of your life in France, in any case, in this patisserie and not restaurant. But, well, I believe the lifestyle is not only what you eat, it's also how you eat it. And the distinct, I'm not a strong believer in the French paradox at all. But I do believe that patients stop during lunchtime and have a decent lunch time and spend time during lunch. This may be different. It has never been looked at seriously, but certainly the time of even, breakfast, lunch, and dinner are decent time where people sit down. Eventually they cook, even they don't cook, they have a decent time for food. Now, it's not all about food or exercise. It's about lifestyle in general. And certainly, I am stricken by, in the clinical trial space at least, by how much we have really smart medication and whether they are acting in inflammation. Likely so. The RAS inhibitors, for example, SGLT2 inhibitors, and many of these medications, which are actually very effective into prolonging healthy life. Now, the issue is whether they have been developed as medication for extending health span rather than lowering glucose or blood pressure, whatever, whether they would have approved for this indication. And this is the core of the debate, I believe. We really need to find out ways that health span becomes an approvable indication. Because let me take just one example. The HYBIT trial, maybe you can remember this one. HYBIT was a trial with a combination of a diuretic and an ACE inhibitor in the octogenarians. Up to HYBIT, we didn't know whether up above 80 years of age, it's worthwhile dropping blood pressure, right? At least on mortality. But HYBIT has demonstrated that at above 80 years of age, if you use RAS inhibitors plus a diuretic in order to lower blood pressure, you can dramatically decrease the new onset of heart failure, stroke, and anything which will shorten health span. This, in my understanding, is the health span indication. This is the health span drug. Whether it worked out only by dropping blood pressure, I'm not sure. So I would like to hear your thoughts about how to move your wonderful basic science theories and inflammation toward the clinical trial and then to the approved label.
All right. So I wouldn't be thinking of a pill in a bottle to start with. I think it's lifestyle would be the first, second, and third interventions to try to change. And Pam, we have Claude Lardinois has said that the time-restricted feeding to only 8 hours is very effective in getting patients to lose weight. And the beauty is that there's no caloric restriction necessary. Is that your understanding? That's a distribution of the caloric intake in time rather than the total calories ingested?
So in our studies, what we see is that there is an inadvertent mild caloric restriction. So on average, we see about a 6 to 8% decrease in calories. In some ways, you're kind of tricking the patient, the participants, because what you're telling them is there's no restriction on what you eat, just eat all your calories between a 10-hour window. And what it inadvertently does is there is a little bit, but what we see is the degree of caloric restriction, for instance, the 6 to 8%, doesn't correlate with the benefits we see. We see a 13 to 15% LDL lowering. So it's the proportion of benefit from that mild caloric restriction with time-restricted eating is not concordant. So what that tells us is that there's other mechanisms involved with fasting that gives us added benefits beyond caloric restriction alone. So as we know from some of the basic science, that there is fundamentally a change in metabolism when we engage in fasting. So after about 10 hours of fasting, we shift from utilization of glucose to fatty acids, and we produce ketone bodies. And so we think a lot of the additional benefits of time-restricted eating comes from utilizing ketone bodies like beta-hydroxybutyrate. And what I think is really interesting is there's some parallels with the SGLT2 inhibitor class, where we think that some of the benefits are from this change to utilization of ketone bodies. I'd love to hear what Dale, as an endocrinologist, thinks about, some of these beneficial mechanisms from SGLT2s, because I think there's a lot of parallels with fasting.
Yeah, so I think
Is it all sugar, or we have to go beyond glucose?
I think we probably need to go beyond glucose, but not completely. I mean, later on I will show you some new work we've done in heart failure, for example, to show that really switching towards more fat metabolism actually helps to dampen down many of them are called toxic byproducts of glucose that can lead to certain side branches from glycolysis, which may increase epigenetic changes, promote inflammatory changes, and so forth. So I do believe that some of the benefits that we are seeing from SGLT2 inhibition really derives from lower levels of insulin, which I think certainly can promote growth in vascular smooth muscle and even contribute to pathological ventricular remodeling in heart failure, as well as some substrate switching, which may mitigate some effects of glucose toxicity.
So certainly the effect of the SGLT2 inhibitors on heart failure has been one of the really great advances in our field. Thank you, endocrinologists, for getting us to the right experiment, even if it might have been for the wrong reason. So I want to tell us, are we going to be able to put everyone with heart failure on SGLT2 regardless of their glucose status? And how do we choose whether to do a GLP-1 receptor agonist or an SGLT2, or Dale, Fayez, Pam, should we combine them?
Yeah, well, the evidence so far in heart failure, at least heart failure with reduced ejection fraction, the SGLT2 inhibitors are extremely efficient. And by the way, even in patients with the CKD and subgroups in CKD, and no matter what is the subgroup of patients, whether they are acting through the metabolism and mitigating everything that Dale has highlighted, it may be one possibility, but certainly they have a real effect on the heart and on the kidneys. And we are here in the core of the discussion about lifespan and healthy aging. It's not only metabolism and inflammation, but maybe indirectly through inflammation, it's really remodeling. They are disease modifying. The heart is being remodeled, and the kidney decline in renal function is slowed, and the onset of dialysis or profound and sustained loss of eGFR is also mitigated by these drugs. So we need to have an open mind on the mechanism of action. We know that we don't know, but it's certainly much beyond, and I'm sorry, Dale, glucose control. I
don't disagree with that at all. Definitely, it is beyond glucose control, without a doubt. But I think we can both share in the glory.
Gradually be cardiologists, convincing the neurologist that cholesterol is important, and we're convincing the endocrinologist that there's a world beyond glucocentrism. So Pam, are we allowed to have black coffee in the morning if we want to fast?
You can, as long as you don't add sugar and milk.
Okay. All right. So audience, take that into account. And I'm sorry, in France, you can't have your café crème in the morning, I guess. So there's some pushback about the intermittent fasting, citing Ethan Weiss's study. Do you have some comments on that, Pam?
Well, one of the issues with that study is the way it was conducted. I mean, whenever you do a clinical study, you have to have a way of monitoring what patients are doing, and you have to have some engagement with the patients, because the way they recruited these patients is through online methods. And they didn't have, you can tell people to do certain things, but you have to ensure that they're actually doing what you ask them to. So for instance, in our study, we have an app, we have them take photos of everything that they're eating. We have them wear a continuous glucose monitor so we can see if glucose levels are changing in response to what they're eating. I think the biggest issue with that study is it's unclear to me if the participants actually fasted for the amount of time that they did. And they just didn't have the ways of monitoring that. And I think that that's the only study really that hasn't shown a benefit. But if you look at a lot of the other studies, both from our group and from Courtney Peterson's group, where they have a shorter eating window of 8 hours, I mean, there's significant benefit, but it's the devil is in the details. It's in the methodology, it's in how adherence is assessed, and really the feedback from the participants of what they're doing.
So Pam, do you want to share some slides with us?
Yes, I do.
Yeah.
Let me, not sure, can you see my slides?
Mm-hmm.
Looks like I've gone to Las Vegas.
Yeah, okay. Well, I actually wanted to start by really commending some of the work that you've done. And it really gets back to some of the topics that you were talking about when we talk about atherosclerosis. This paper that you wrote is probably my favorite paper of all time, talking about the pathogenesis of atherosclerosis. And it really opened my mind to that when we talk about cardiovascular disease, it's not a focal disease. For many years, we always thought you put a stent in a blocked artery, you fix the problem, you bypass the artery, you fix the problem, but that's not the case. It's really a diffuse systemic disease. And as you pointed out, inflammation is such a key driver of this disease. And we're learning from some of the recent trials like Hantos, and more recently with colchicine, that we really need to be thinking about inflammation as a target of atherosclerosis and not just lipids. And this is something that I think most physicians and patients don't understand, which is that plaque is very sneaky. We're just so focused on stenosis. We're focused on plaque that causes narrowing of the artery, plaque that causes hemodynamically significant stenosis that leads to an abnormal stress test. But in the prevention space, we need to be thinking about all plaque, even that 30% plaque or the 20% plaque, because that's the plaque that in the right circumstances with inflammation leads to plaque rupture and a heart attack or a stroke. So you really beautifully pointed out in your paper this beautiful eccentric remodeling that the artery can do and how sneaky plaque can be. And then clinically, this is something that I always tell to my patients, which is that stenosis is that's less than 50% is what leads to future heart attacks. So this is where all of our work, both in the basic science, translational science, and clinical realm, need to come together to really address these hidden plaques. What we've also seen is that medical management is very beneficial and lifestyle management is very beneficial. And we talked about some lifestyle strategies. So the discussion question for the group is what should we be recommending to our patients that really addresses some of the points that Peter brought up earlier, and then this underlying pathogenesis. And I'll end by showing you some figures that we've developed in our group to just talk about some simple strategies to our patients, which is really focus on evidence-based therapies. You alluded earlier to the Mediterranean diet, and that's the most evidence-based diet. We already talked about fasting. There's some really great evidence-based supplements. Icosapent is a prescription, but in many ways it's fish oil. So those are the kind of strategies that we should be gearing our patients towards. And finally, I will conclude, this is something that I came up with because I wanted to depict to patients what are all of the things that they can do in terms of what they have control over. You talked about genetics, but there's a lot of things that the patients have control over. They have control over the content of their food, the amount of calories that they consume, how they eat it. Do they eat all the way till they go to bed, or do they fast for 14 hours? Do they exercise? Do they do the half marathons like Peter? Do they eat their meals quickly? Do they do small meals? So these are all just some food for thought, and I'd love to get input from our panelists on.
Well, I'll make a first comment if you don't mind. I mean, what I'm really seeing here, Pam, is diabetes prevention, right? I mean, I'm really seeing that, what you have just described in terms of the jackpot is a lifestyle that would really stave off many of the metabolic consequences that we are really living in. I wouldn't even say in the Western world, I would say in pretty much the entire world now, in terms of the growth of obesity, the metabolic syndrome, and its cardiovascular consequences.
So, Dale, we've learned about all of the wonderful effects of GLP-1, and is there a tension between the incretin hypothesis and the intermittent fasting? Because it seems if you're going to have more frequent meals, you're going to have more of the incretins, and you're going to have more of the putative beneficial effects of the incretin. Is there a tension there?
I mean, I think we have to be driven by the data, right? I mean, I think that the data are certainly quite compelling that GLP-1 receptor agonists are having very striking microvascular, cardiovascular benefits. Whether or not the mechanism is linked to signaling downstream of GLP-1 per se, as opposed to its effect as an incretin, I think that still remains to be resolved in my mind. But I do think that mechanistically what we're seeing with the incretins is very distinct from, say, what we're seeing with SGLT2 inhibition, and probably also distinct from what we're seeing with sort of dietary and lifestyle modifications that also converge to improve vascular health.
So Dale, did you have some slides you wanted to share?
I do have some slides that I want to share. Let me just share my screen here. 1 second. Yeah, so I'm just going to just talk a little bit about one aspect that we haven't touched on a bit, which is heart failure. And this slide really just, I think, speaks 1,000 words that heart failure is a disease of aging. So this is a large population study from Scotland. The blue line are non-diabetics. You can see between the age of 60 and 80, the exponential increase in heart failure. But importantly, if you have diabetes, the curves shift quite strikingly to the left. And this next slide just shows the same data, but pulling out people with prior ischemic heart disease. And again, you can see that the diabetes effect still holds true. And so I think an important point that is important.
Yeah, I'm sorry to interrupt, but I think your slides are cut off. Could you go into show mode? Maybe that'll help.
Sure. Yeah, let me change that. I'm sorry. Use slideshow. How is that? Is that better?
Yeah. Now we're cool now.
Okay, so I just want to just reiterate the point here that heart failure occurs with aging, but diabetes shifts that relationship between aging and heart failure incidence quite markedly to the left. And what this slide is really showing is that heart failure and diabetes share many common metabolic correlates. Specifically, they're both insulin-resistant states. And the way that the heart adapts to this insulin-resistant milieu might give us some insight into the accelerant effect of diabetes on heart failure. And this cartoon just attempts to summarize that, in the outer part of the donut here, which is kind of the abnormal metabolic milieu, there's really a panoply of intracellular toxic events that occur that then will, contribute to the increased risk of heart failure, which is observed. We study insulin signaling quite a bit, and so we have, certainly preclinical mechanistic data linking altered insulin signaling, certainly downstream of hyperinsulinemia, as well as aberrant signaling with beta receptors that can certainly contribute to ventricular remodeling in the heart. And we think the mitochondria is also central to this effect, and that multiple metabolic hits, specifically lipotoxicity, glucotoxicity, oxidative stress, and insulin resistance may contribute to mitochondrial dysfunction. And to drill a little bit more into metabolism, that in the context of diabetes, there is inefficient fat metabolism in the heart because of the mitochondrial dysfunction, leading to reactive oxygen species overproduction, which contributes both to tissue injury as well as to inefficiency of mitochondria. We've been talking quite a bit about various therapeutics in the diabetes space, and this slide really makes the point that diabetes is associated with heart failure, but really only one therapy, SGLT2 inhibitors, seems to have an impact. But it doesn't bring the risk down to zero. And so I would argue that there are probably other pathophysiological mechanisms that are contributing to the increased risk of heart failure and diabetes that still may represent important targets for therapy moving forward. Finally, I just want to talk a little bit about heart failure in the absence of diabetes and make 2 points. One is that mitochondrial dysfunction is a strong characteristic of heart failure. But when there's mitochondrial dysfunction, it isn't just about the absence of ATP, but when you have mitochondrial dysfunction, you have overflow into other metabolic pathways. For example, the pentose phosphate pathway, for example, and other pathways that impact cardiac remodeling. And there's no data in humans to suggest that that is true. I'm going to focus on glucose. This is a paper that we did in humans looking at heart tissue at the time of LVAD implantation. And we did metabolomics on their hearts and saw a striking accumulation of glycolytic intermediates in the unloaded heart. And so we want to understand it a little bit better, and we made a mouse that we inhibited the ability of pyruvate to enter mitochondria, which led to accumulation of glycolytic intermediates. Quite remarkably, these hearts actually failed. Sorry, I jumped a slide. These hearts actually had an age-dependent cardiomyopathy, as you see here. And then we said, well, what if we gave them another substrate and we give them either a high-fat diet or a diet that raised their circulating ketone levels? And what we in fact saw was a very dramatic rescue of the cardiac hypertrophy and the heart failure in these animals. And so when we looked at the mechanism, we saw that in fact the overaccumulation of glucose toxic intermediates, for example here, O-group modifications, was reversed on the ketogenic diet. And finally, another recent paper from our collaborative group with University of Utah, we did flux metabolomics, again, in patients with heart failure who had LVADs and then had recovery. And interestingly, we saw metabolic rewiring, again, of glucose intermediates, some of which, for example, were leading to enhanced biomolecule synthesis, amelioration of reactive oxygen species, leading to cardiomyocyte repair and myocardial recovery. So what I tried to do in this quick survey is just really to mention that that glucose is probably in a variety of ways contributing to ventricular remodeling and heart failure, certainly in the context of diabetes, but even in individuals who are not diabetic as well.
So whatever union card we hold, cardiovascular or endocrinology, we end up converging on the same common pathway. So
Absolutely.
we're more similar than different. So Faz, one of the real revelations for me from looking at the data from the dapagliflozin study, Declare, Timmy number whatever, was the finding that people who didn't have heart failure at the beginning of the study had a reduction in heart failure and better outcomes when they were treated with the SGLT2 inhibitor. Does that mean that when we're sitting across from a patient with diabetes in the clinic that doesn't have overt heart failure, that actually they have latent heart failure or they're at risk? I mean, how does that change your perspective when you're sitting across from a patient with diabetes?
Yes, well, there is a very strong suggestion actually that many patients with diabetes are sitting there with heart failure undiagnosed. And actually, there have been a number of attempts in Declare and other studies in order to predict ejection fractions. Quite a few of them have actually low ejection fraction, but majority have preserved ejection fraction. And we have been in this crosstalk with diabetology, they have been teaching us to screen for pre-diabetes and diabetes on the one hand, and indeed in any heart failure trial, diabetes and non-diabetes, we have 30, 40, 50% of patients have diabetes and 30% more have pre-diabetes. So we have quite a bit of glucose intolerance in our heart failure population. But reciprocally, we have been advocating and lobbying the diabetologist to screen for heart failure and measure on the most systematic basis NT-proBNP or perform echocardiography, because many of the diabetes patients have such latent heart failure, what we call stage B heart failure, and SGLT2 inhibitors just slow the progression to symptomatic heart failure. So that's the clear, consistent finding from most of the trials. And actually, heart failure, prevention of heart failure hospitalization is the single outcome which is consistent across all SGLT2 inhibitors, all of them. Well, they do improve renal outcome, but in and out, and CV death in and out. But prevention of heart failure hospitalization is the single outcome which is prevented across all trials.
I wanted to add, as someone who uses a lot of SGLT2 inhibitors, one thing that really strikes me about our patients with diabetes is we have the approach to diabetes and heart failure all wrong. We really wait for patients to manifest symptoms before we treat. And really what we should start is really looking for mild structural changes, and even just prophylactically starting patients on preventative therapies. I mean, the SGLT2 inhibitors have an incredible impact on remodeling. So there was a study where they did cardiac MRI and they measured left ventricular hypertrophy, and there was actually regression of left ventricular hypertrophy in these patients. And the other thing that I've seen as someone who reads a lot of echocardiograms is when you have longstanding diabetes over 5 years, you always have diastolic dysfunction. It's there and it's just waiting to present. So why not treat when patients just get diagnosed with diabetes, start an SGLT2 inhibitor and prevent that progression? You're smiling, Dale.
I'm smiling for the obvious reason, right? I mean, I don't disagree with you in principle. It's very, very provocative. It raises some questions. Number one, should we be screening all diabetics in our clinics with echo? Because obviously they are enriched with diastolic dysfunction. So that's the first question, right? Number two, do we imagine designing a trial, right, to look at a hard endpoint, like, progression to heart failure and so forth in asymptomatic patients? How long would we follow them for, how many, etc. And the last thing I'm thinking, putting on my chair medicine hat and dealing with, money people all the time, is the implication of the cost of doing all this screening and implementing therapy on sort of quality adjusted life years. I suspect it will probably be positive, but the argument will be, how do you justify that added upfront cost of screening all these people and starting therapy without, a clinical trial to prove that it's going to prevent it. So I just throw it up because I think that's where that's an important policy perspective that we have to address if we're going to go in that direction.
Yeah, so you're a trialist, so how do we crack this nut? People say that we should start statins in youth, but how are we going to deal with that as clinical trials? How are we going to build an evidence base?
Well, I wouldn't comment statin, but just to get back to the situation of heart failure detection or prevention, what trials say is that diabetes patients should be put on SGLT2 inhibitors, no matter. So maybe the most cost-effective way is to get them on this medication the fastest possible, and they have all good reason to get a RAS inhibitor as well. With the announcement of the non-steroidal MRA, which is finerenone, being very effective in diabetes kidney disease, and we have also the evidence that this class of medication is very effective in heart failure. And therefore, the shortest and most cost-effective way in diabetes is to get patients on SGLT2 inhibitor, a RAS inhibitor, and MRA. Not necessarily going for echocardiography or NT-proBNP. This wouldn't happen necessarily. I would really go shortcut getting them on this medication because we have a solid evidence of the three factors in prevention cardiovascular disease in general and heart failure in particular. So then getting back to the question, Peter, about how early to start medication, I would ask you actually about this Orion trial and inclisiran. and I heard Dr. Braunwald at some point having a conference on coronary artery disease is dead. If you start early enough, you may kill coronary artery disease because you are going to be immunizing patients against cholesterol. So what is your take on this?
So I think it's Brown Goldstein who said at the end of the last millennium, a heart attack gone with the century. And I was still a chief of cardiology, so I didn't want heart attacks to go away at that point. And they were wrong. And what I've heard Dr. Braunwald is not to say the negative, but say the positive. He said, how to live to be 100. Get a flu shot every year and go to the doctor just once a year to get your shot of inclisiran, which is the siRNA that's directed against the PCSK9, which will lower cholesterol. So if we have safety, I think we may see that. So let me ask you folks. So Faiz, you probably don't have this kind of patient, but we have these very aware patients, often patients of great means, who come in for well person care, and they want to know whether they should be taking metformin for longevity. So as we're talking about starting anti-diabetic medicines early, what's your take, Pam, Dale, Faiz, about metformin as a longevity drug?
You go first. It's a tough one. You go first.
I think it's a tough one. I think there is some good data to suggest that metformin is beneficial, but I think overall the metformin data for cardioprotection is weak. So I'm mixed on it.
Mm-hmm.
Yeah, and so I'm gonna just putting my endocrine diabetology perspective on this. There was a very famous trial called the Diabetes Prevention Trial, DPP, classic paper, where people at high risk for advancing from the metabolic syndrome to diabetes were randomized to lifestyle modification or metformin, and then there was also a rosiglitazone arm that was stopped. And the lifestyle modification completely beat metformin in terms of the risk of progressing to type 2 diabetes. So I mean, there was a metformin benefit, for sure. But I think the message really would be, you can't sort of eat your cake and have metformin, right? In other words, if you want to really derive kind of optimal benefit, my advice would be, let's work on the lifestyle part first. Let's look at quantifiable risks, including family history and other things, and then let's have another conversation about metformin, as opposed to just giving it out as in the drinking water.
Yeah.
I'm more bullish for a preventive strategy, things like icosapent ethyl. And I'd love to see a true primary prevention trial with icosapent ethyl, even SGLT2s in non-diabetics. We saw both from the Emperor Reduced and the DAPA heart failure trial, half the patients didn't have diabetes, and there was benefit. So I'd like to see those two really studied in a primary prevention population.
You're raising a very important issue, which is what clinical trial. Primary prevention is really challenging. You need to expose patients to long-term, thousands of patients, and therefore we will need to rely on surrogates, on enrichment, and there are methods to move around, but the short answer to Peter's question is, show me the evidence. And certainly metformin has a great rationale, as much as SGLT2 inhibitors, by the way, but certainly we need to build the evidence, and having trials with primary prevention is time consuming, maybe very expensive, and therefore I know that the NHLBI, I've had a discussion with them, and FDA actually willing to move into patient enrichment strategy as an inclusion criteria on the one hand, and on the other hand, relied on imaging or surrogates, and keep the trial evolving in this kind of pragmatic design, and therefore end up by collecting hard data later on and have still some intermediary expedited access pathway and conditional approval. A very complex issue, but very important really to discuss in order to make these hypotheses become a reality.
Yeah, so going back to metformin, because it's an inexpensive drug and it's a drug that we know, and actually some of the labeling prescriptions have been lifted about renal failure and stopping before angiography and things. So, we have accepted that it prevents myocardial infarction based on UK PDS study 34 in overweight individuals, which had a teeny number of events. And it was in the pre-statin era. And based on that, metformin is at the base of the anti-diabetes therapy in most of the guidelines. Is it time to rethink that? And Dale, let me put you on the spot and ask, should metformin actually be at the base in the era of statins?
Yeah, so I think if you look at many pragmatic trials that have looked across millions of people with statins who have taken metformin, I think there's still evidence in my mind of a benefit, certainly with certain endpoints, and certainly with heart failure for sure. So I do think that it is safe, inexpensive, widely available, very efficacious, and so I do feel it has a role. I think the debate really now is, should it be first? And I know that there's a debate right now between Europe and the ADA in terms of SGLT1 first versus metformin first. And in fact, as I had a little chat with one of the participants in the chat box, raising the issue of cost effectiveness being heavily weighted in the ADA recommendations in terms of SGLT1 versus metformin. And my response back was, very interesting, maybe a decade or 15 years from now, when SGLT2s are potentially off patent, right? And cost is not necessarily as big a factor. To what extent is that going to reshape the guidelines? But of course, there'll be a decade's worth of experience as well.
So, folks, we started out by saying it's lifestyle, but then when you look at the evidence base in heart failure, we have the ACTION-HF that was pretty much null. And then we have a look-ahead trial that was a superbly conducted trial with a lifestyle intervention that's much more successful than most of us could do in our office practices, yet it was a null for cardiovascular endpoints. So do we sweep those results under the rug, or do we have to re-examine our primacy of lifestyle change? So let me start with Faiz, because you can bring me up to date on what we know about heart failure and physical activities and intervention.
Well, this is not in the space of prevention, but symptomatic heart failure, we have been struggling for long before we get our patient to have rehabilitation, because for when I started my medical education, heart failure patient, we just asked them to stay home and not move around until we had smaller trial, and we ended up by having the HF action trial, and this was really reassuring because it was felt that aerobic exercise was safe and effective. So, and I wish that we could have this sort of trial, because it was really rigorous and very demanding. And by the way, it was an NIH-funded trial, and the only non-American patient were enrolled in France. I was coordinating this. I was very pleased to be part of it. But I wish that this sort of trial can be also performed in primary prevention. It's more challenging, lots of methodological traps and crossovers and drop-ins and dropouts. And this is the main reason of this primary prevention trial being extremely complex. The adherence is very challenging. So I doubt, and actually, again, in the heart failure space, we're still advocating low sodium diet, but we don't have any evidence for low sodium, because we haven't been able to succeed one single trial with low sodium, a good methodology.
Right. So next time we'll have to invite Salim Youssef, and that'll inject a little controversy because we're agreeing too politely with one another. So we have about 5 minutes left. So let me ask people for, in the spirit of what debates should be, for their summative statements. So Dale, what's our take-home message from this discussion? How do we combine lifestyle and drugs, and how can we help our patients or our
Sure.
populace?
Yeah. So I think that a combination of lifestyle and judicious use of certain medications and diets really will have a very profound effect on systemic metabolic homeostasis, then in my mind is a soil in which a lot of cardiovascular disease blossoms, as it were. And therefore, I think that there needs to be a strong emphasis on that. And also I would agree with Pam, starting earlier as opposed to waiting when people present clinically.
So Fayez, what's your take-home lesson in 90 seconds or less?
Well, I believe that lifestyle trials are going to be very challenging, and I don't believe that we'll have anyone which would be reliable enough. So we will have to rely on lifestyle as a faith or common sense, and therefore move up to other prevention trials based on drug therapy, which are much easier to perform, even though the main issue in this prevention space is the length of trial, as I mentioned earlier on, and also the rewarding, whether pricing a preventive therapy is attractive enough for industry to develop large outcome trials. This is also a very important issue to be discussed at a society level.
Great. And Pam, what's your lesson? Also, let me just mention that Joe Cook, in our question and answer, has said, how precise is that 14-hour period? You sort of talked around that, but maybe you can tell us what the confidence intervals are around 14 hours.
Ideally, 14 hours seems to be the sweet spot. So we've looked in our animal studies at different windows, whether you fast for 16 hours or 14 hours. The 14 hours seems to be where you have the most adherence and the most cardiometabolic benefit. It's not, you have to be rigidly adherent to 14 hours every single day. I mean, we've seen in our animal studies that if you cheat and you have one day when you're not doing 14, it's fine. But I can't answer that question precisely because we don't have an incredible amount of data comparing all of these different windows. But I think my take home for this talk or this panel discussion is there is an elegance to combining lifestyle strategies with pharmacotherapy, and it needs to be customized and personalized to each individual patient, because not some of these generic recommendations, Mediterranean diet, fasting, it's not applicable to everyone. People's metabolic are different, people's genetics are different, people's background medical therapy is different. So you really need to figure out what is the optimal lifestyle strategy based on some of the underlying characteristics of the patient.
So Pam, you practice where there are a lot of people who are keeping the supplement industry afloat in Southern California in search of the fountain of youth. So you've mentioned a few things, but Zodu in our question box asks what vitamin supplements are actually evidence-based. You mentioned magnesium en passant. You mentioned icosapent-ethyl, which is a prescription-grade fish oil. Beware of the over-the-counter fish oils, which are not quality controlled and have impurities. What do you tell your patients when they come to you with their list of supplements that they're taking? So most of them are not evidence-based, and I really think that we need to get away from supplements and pharmacotherapy and just really categorize, is there data for it or is there not data for it? I think a lot of it is based on what their biomarker profile reveals. So for instance, if someone has an elevated high sensitivity CRP, they have elevated triglycerides, this is a patient that you might want to steer towards a good fish oil supplement with EPA, kind of extrapolating the icosapent-ethyl data. The other supplement that has some good evidence base is vitamin D in terms of inflammation. And now we're seeing with COVID, there's some data suggesting that higher levels of vitamin D are protective. We're also seeing in some basic science studies that patients with low vitamin D are more predisposed to go from pre-diabetes to diabetes. So those are, I would say, the main supplements that I rely on: fish oil, vitamin D, magnesium, and some of it is just really based on what that particular patient's blood work reveals. Great. So unfortunately, it's time for us to wrap up. And I would say that my bottom line is that, we all are very confident in our evidence base and congratulate ourselves for practicing evidence-based medicine. But what I'm hearing from this panel of experts, including myself, is that there's a lot more that we don't know than we do know, and that the gray areas and the cracks in our knowledge are tremendous, and that the challenges of actually doing the proper studies to take us to a level of rigor that we expect to try and face the challenge of these chronic diseases is enormous. So we have our work cut out, ladies and gentlemen, and it's just been a tremendous privilege to share thoughts with you, and I hope that we can reconvene and see if we've made any small steps towards progress next time we get together. And maybe invite Salim. Yusuf.
Peter, yes, indeed. Yusuf should definitely be brought in next year. But this was such an engaging and enjoyable discussion. You guys should actually go on the road. This is a great act. I say bravo. I know that there are many other questions we saw in the chat room and in the Q&A, and you'll have a chance, those who want to come tonight to the cocktail, or this evening to the cocktail hour starting at 6 o'clock, to maybe field a few questions. But again, many thanks. I also wanted to say about Fayez, and you mentioned this, Peter, that he has a foot on both sides of the Atlantic. Fayez has founded one of the most outstanding conferences of any I know. It has more FDA participation than any other professional meeting I know of. And it's held in Washington every year in December, usually at the French Embassy, but unfortunately it will have to be like this conference, virtual. But I'm so pleased and honored to say that there will be, for the first time at the CVCT conference, a session on health span. So this topic is going to be discussed again in December, and I would invite everyone to sign up for the conference. It's going to be a great one, not just for that session, but for many others. So again, thank you, Pam, Dale, Peter, and Fayez. Terrific, and bonsoir, Fayez.
Thank you. Bye-bye.
Bye. Thanks a lot.
Bye-bye. Thank you.